Okay. So this is not. Where do you pause it now? Sorry.
Next. Next.
Where do you pause it?
Hmm.
Where do you pause it?
साउंड दे दिया ना शुरू करो
Okay. So what I'm showing is a very simple. It's not a complication. A very simple way to do things. This is it's a simple giant retinal tear. The typical steps where you do a good vitrectomy, you clean the anterior flap of all attachments, and then mark the edge, and it's ridiculously simple. That's why, but it's a bit controversial. So you're flattening the retina using PFCL. And the whole concept of this is that you can leave the PFCL in for 7 to 10 days. While what it does is that it avoids slippage, it avoids multiple maneuvers. The surgery is very fast, and there's the requirement of positioning is also not there. Face down, whatever positioning is not there. So this is a technique that has been used extensively places like Australia, US, sometimes some places where this is the only interesting step. That's why it's taking so long. Okay, so you're flattening the retina now. Subsequent to this, we'll be doing some laser, and that's it. Then you call the patient after 5 to 7 days. The laser marks take up. You can just remove the PFCL, and that's the end of it. And what are the why are we discussing this? What are the concerns? Some of the concerns is the toxicity of PFCL, which is basically to the pharmacological toxicity and the mechanical pressure. But there are studies which show that it is quite safe if taken out by around 7 to 10 days. Advantage: patient goes home, lies on the patient's back, no need of prone positioning. That's 15 days actually, but you can see all the laser marks around, and now all you have to do is a very simple surgery of removing the PFCL, well attached, no complications of PFCL, oil removal, no complications of slippage, no retinal wrinkling. So it's a good technique, especially if you have a patient who cannot position. And so that's it. And just a little bit more, there's a, so this technique has also been used for inferior PVR. So if you have an inferior PVR, I have a small video of that also. For inferior PVR, you can do basically you can do the same thing. It's supposed to come now. Yeah.
You didn't leave any tamponade after
No, you don't need tamponade. Air is good enough because the laser marks have already come.
No, basically you are not using silicone oil.
No.
But there is such a big area of BRRP choroid complex that can induce PVR. What oil does that it minimizes the space between the BRRP choroid and the tamponade.
We don't know that.
There is no space for the PVRogenic membranes to proliferate.
We don't know that. I'm sorry, I'm arguing, but
still,
yeah,
that may happen.
So the point is that in the first 7 to 10 days, if you achieve retinal reattachment well, okay, and you have a well attached good laser and all those things, you're not, are you really worried about PVR happening? I mean, these are things that we've done, and we don't see that much PVR recurrent membranes later. The key of this is that it's a very quick surgery.
No, that's true.
No, quick not for the surgeon, for the patient's eye. You're not fiddling around with the patient's eye too much inside. So, thank you. Sorry.
Sir, okay, please, sir, any comment?
Yeah, agreed. It's a good technique, except for the fact like this component of the mechanical issue on the retina has not been shown, has been earlier shown to be detrimental, but now it's not possibly. So I do use this technique, but not essentially for like giant retinal tears with very severe contracted retina, which is not opening up. I leave the PFCL in place for about a week to 10 days and then redo the surgery. But then I still haven't come across to doing only PFCL inside, because the other concern is PFCL doesn't have the surface tension of the oil. So there's a possibility it tends to break into like multiple bubbles very easily. So if there's a PVR, then there's a possibility of it going subretinal. All those issues can happen.
Yeah, that's what I was thinking of asking. If there's PVR there and if you're not relieved it, and the patient is moving, in Madurai also we do it sometimes, and the patient is in admission for a week. So also, how do you take that consent early ahead that this is going to be a staged surgery? That it's not actually a resurgery; it's a staged surgery. It's surgery in 2 stages. This is also what Dr. Steve Charles showed in his webcast also, for inferior PVR and nasal breaks.
See, a couple of things here is that you have to be sure that the patient is going to come back to you.
That is
the most essential point in this.
Consent you have to take.
Yeah, and the second point I can tell you is that sometimes you need to do, sometimes when PVR, you need to do a trial by air to make sure that, a trial by air, to make sure that the retina is flattening reasonably well. Because under air, you can absolutely be sure whether the retina is flattening. In those patients, you're not going to, if it's not flattening, you have a wedge, you have an edge, you're not going to push in PFCL inside those patients. So if you have a doubt that the retina is going to be tented and the PFCL is going to be pushed under, those are not the patients where you do this.
One other limitation will be an extremely anterior
Superior.
GRT and superior GRT.
Yeah.
This may not be tamponaded adequately with this.
But probably the availability of the heavy silicone oil, if would have been there, then what would be
Heavy
your
silicone
choice?
oil negates the advantage what he tells, because heavy silicone oil is for inferior PVR where you want a longer tamponade. Here you are looking at a shorter tamponade. We are trying to get the eye rehabilitated faster. So heavy silicone oil and this we cannot be equated. This technique cannot be equated.